Welcome to our explainer on AV block. If you've ever found yourself staring at an ECG, totally confused by the different degrees of heart block, you are absolutely in the right place. We're going to break it all down, and we're going to focus on the high-yield stuff you really need to know, both for your exams and for your patients. So here's our game plan. We'll start with the basics. What even is AV block? Then we'll look at the AV node's super important job as the heart's gatekeeper. From there, we'll dive into the different degrees of block, figure out how to decode them on an ECG, talk about management, specifically when to pace, and we'll wrap up with some key clinical pearls.
All right, let's jump right in. First things first, what are we actually talking about when we say atrioventricular block, or AV block?
At its heart, pun intended, AV block is just a communication problem. It's a glitch in the electrical signal traveling from the top chambers of the heart, the atria, down to the bottom chambers, the ventricles. The signal is either too slow, or sometimes it just doesn't get through at all.
The best way to think about the AV node is like an electrical gatekeeper. Its main job is to put a tiny pause on that electrical signal. And that delay isn't a bug, it's a feature. It's absolutely crucial because it gives the ventricles just enough time to fill up with blood before they get the signal to squeeze.
So, what happens when that gatekeeper starts to fail? Well, the consequences can be pretty serious. A heart rate that's too slow can cause people to suddenly pass out. We call those Stokes-Adams attacks. It can also lead to heart failure over time, and in the most severe cases, it can even cause sudden cardiac death. So yeah, this matters a lot.
Okay, so let's zoom in a little bit on this gatekeeper. How does it work? And maybe more importantly, what makes it fail? Because if we understand the why behind the block, everything else makes a whole lot more sense.
The AV node isn't just on autopilot. It's constantly being adjusted by our autonomic nervous system. Your sympathetic system, think fight or flight, is like the gas pedal. It speeds up conduction when you need it. And then there's the parasympathetic, or vagal system. That's the brake, slowing things down when you're resting.
And this brings us to a really key concept. The gatekeeper can fail for two main reasons. It can be a functional problem, meaning it's temporary. This could be from an athlete having a really high vagal tone or from medications that are hitting that brake pedal a little too hard, like beta blockers or calcium channel blockers. Or it can be a structural problem, meaning there's actual damage to the wiring. This could be from simple aging and fibrosis, a heart attack, inflammation from something like myocarditis, or even an infiltrative disease like sarcoidosis.
So we classify these failures into different degrees, and this isn't just for fun. It's absolutely critical. The degree of the block tells us how much risk the patient is in, and of course, what we need to do about it.
Let's start with the mildest form, first-degree AV block. With this one, our gatekeeper is just consistently a little bit slow. But, and this is key, it never actually stops working. Every single signal gets through, just with a predictable little delay each time.
What this looks like on an ECG is a PR interval that's longer than 200 milliseconds, or one big box. But the most important thing to remember here is that every single P wave is still followed by a QRS complex. It's really just the delay, not a truly dropped beat.
Okay, now things start to get a bit more serious with second-degree AV block. Now, our gatekeeper isn't just slow, it's become unreliable. It actually starts dropping beats. And this is where we have to talk about two very different types, Mobitz I and Mobitz II. Knowing the difference is a really big deal.
First up, we've got Mobitz type I, which you'll almost always hear called Winkebach. I like to think of this as a predictably tired gatekeeper. The PR interval gets a little longer, and a little longer with each beat, until finally, the gatekeeper is just too worn out and drops a beat completely. Then it catches its breath, and the whole cycle starts over again.
Okay, let's trace this out on the ECG together. Find the first P wave and measure that PR interval. Now look at the next beat. See how that PR interval is just a little bit longer? And then the next one is even longer still. This is the going part of the pattern. And then finally, after this P wave, poof, no QRS. That's the gone. This predictable repeating pattern of lengthening and then dropping is the absolute classic signature of Winkebach. Now, in sharp contrast, we have Mobitz type II, and this one is much more concerning. This is a dangerously unpredictable gatekeeper. There's no warning. There's no gradual fatigue. Beats are just dropped, suddenly, out of the blue. And that usually points to a much more serious problem deeper in the heart's wiring. So let's compare that last ECG to this one. Again, let's trace it. Look at those first couple of beats. The PR interval is exactly the same. It's constant.
The third beat, same PR interval. But then right here, you get a P wave with nothing after it. It's a sudden, unpredictable drop without any of that warning lengthening. And that is what makes Mobitz 2 so much more worrisome.
And finally, we get to the most severe form, third degree, or complete AV block. In this case, our gatekeeper isn't just unreliable anymore, it has completely shut down. There is zero communication getting from the atria down to the ventricles.
What you get is something called complete AV dissociation. The atria are just firing away at their own pace, making P waves, and the ventricles, they're forced to rely on their own much slower backup pacemaker to create QRS complexes. If you look at an ECG, you'll literally see P waves and QRS complexes marching to the beat of their own separate drummers, with absolutely no relationship between them.
Okay, telling the difference between Mobitz I and Mobitz II is a classic exam question. But more than that, it's clinically vital because their prognoses are just worlds apart. So let's put them head-to-head and really lock in the differences.
This table right here is your money slide. The PR interval tells you the behavior, lengthening versus constant. But the most important row on this whole table is location. See, type 1 is a problem in the AV node itself. It's nodal. It's often benign and might get better with things that speed up the AV node. But type 2, that's a problem below the node, deep in the main electrical cables of the heart, the His-Purkinje system. And that's why the QRS is often wide, and it's why it's so dangerous. That system doesn't have a good backup plan. It's much more likely to fail completely.
All right, so we've gotten pretty good at identifying the problem. Now for the million-dollar question. How do we fix it? And really, management comes down to two things. One, is the patient stable right now? And two, what type of block are we dealing with?
Okay, you walk into a room and you have an unstable patient with a dangerously slow heart rate. What do? First up is atropine. It's an anticholinergic, so it's basically like cutting the wire to that vagal brake. If that doesn't work, your next step is to hit the gas with a beta agonist, like dopamine or isoproterenol. But remember, these are just temporary fixes. If your patient is still unstable, or if they have a high-degree block like Mobitz 2 or third degree, it is time to take over with temporary pacing.
Now, when we talk about long-term treatment, the guidelines are crystal clear. You've got complete heart block, you're getting a pacemaker. Any kind of symptomatic bradycardia from an AV block, pacemaker. And here it is, the single most important takeaway for your exams and your practice. Mobitz type 2 gets a pacemaker. And listen closely, it gets a pacemaker even if the patient feels completely fine. Why? Because that rhythm is a ticking time bomb. It's unstable, and we just can't risk it progressing to a total shutdown. That's a non-negotiable.
Let's boil this entire explainer down to one single essential rule. You can often watch and wait with a first-degree block or a stable asymptomatic Mobitz 1. But Mobitz 2 and complete heart block are never benign. Ever. They represent an electrical emergency just waiting to happen. The second you see one of those on an ECG, your brain needs to immediately shift gears. You need to be thinking pacing.